I want to spend a little bit of time talking about sort of the state of what we know in terms of how to prevent negative responses to trauma, and I'll also be talking a lot about what we don't know. Some of these, some of what I'll go over, I think, will probably have less maybe direct applications to some of what's happening here in terms of prevention, and some of it will. And I'll try to be very attentive to that as I go through, to really think about how this sort of applies to the setting that everybody's been starting to lay out. So just to sort of give you a quick snapshot of what I want to do, I want to talk a little bit about how frequent trauma and negative responses to trauma are, and then be able to move on to early prevention attempts, which I'll then sort of show you actually weren't super successful, and talk a little bit about why. And then talk about sort of where to go from there, which is to think about what do we know? What's our current state of knowledge about how negative responses to trauma develop? And what does that knowledge tell us then about what we can do in terms of prevention work? And then I'll try to close by thinking about sort of where we are and where we should be headed. So with that in mind, I want to talk a little bit about frequency of trauma and negative sequelae. And I want to mention that these are data that do come from US populations, but they have been replicated in several other countries as well. So, so I think that I don't think it'll be incredibly shocking, but I do want to sort of have this as context. In the US we do use DSM, but the definition of trauma in the DSM and the ICD are both pretty similar. And it's just a way to sort of make sure we're all thinking about the same thing when we talk about what is a trauma. Now, which events? It's spread, and you'll see that many of the most common ones are things like disaster, an accident or fire, or an assault. But what I want to point out is this next part here, the frequencies of people who develop post-traumatic stress disorder after experiencing a trauma is actually quite low. So the vast majority of people who go through these things end up okay, normal, as we were talking about before, in the context of not developing post-traumatic stress disorder. When I get to the end of the talk, I'll talk a little bit about whether or not that is the same thing. Not having PTSD means you're just fine. But in terms of the way that we think about it, the vast majority of people do not respond with pathology to a trauma. The most common types of responses where you see PTSD developing is in the sort of interpersonal violence. So whenever you've seen combat, when you've seen an assault on a person, or you've witnessed an assault, that tends to be the most common way in which people develop a response like that. What are the typical responses to trauma? We'll see here is what's confusing, because in reality, immediately after a trauma, it's quite common. In fact, it's almost everyone who has something that looks like PTSD in the first week or so. It's not PTSD because you need to have those symptoms for a handful of months to really meet criteria for a diagnosis. But most people experience symptoms like this. They experience intrusive thoughts about it. They have nightmares about it. They want to avoid thinking about it. All of that is actually quite common. And then it slowly declines over a period of 1 to 3 months. What you see here is one graph from a study that was done back in the early 2000s that sort of looked at individual trajectories of symptoms and recovery from those symptoms after a trauma. And you see there's a peak and then it sort of drops off. So that's the typical pattern. What happens after a trauma? Most people, what you usually see are extremes at either end. So you see people who appear overwhelmed emotionally or completely numb emotionally. You see people who are over-aroused and jumpy and easily startled, or in shock and seemingly sort of dazed and confused. You also see people who want to talk a lot about it or who want to avoid talking about it at all. And these are fairly typical responses. So one of the things that we know, actually, is that one of the things that predicts long-term PTSD is that tendency to avoid early on. So the people who are more avoidant, who don't want to talk about it, who don't want to think about it, and who show sort of a real dampening in those sort of responses shortly after a trauma, they're actually the people who are often most likely to develop PTSD down the road. So early prevention attempts really took that on and said, well, that's what we should do. And here's one of the sort of big lessons, right? They said, well, gosh, if the avoidance, right, if not talking about it is what leads to PTSD, well, we should have people talk about it. And so one of the first attempts was called psychological debriefing. There were several different variants of this, and the idea was you'd have a 1 to 3 hour session within 48 hours of the event, so very, shortly after the event. You bring people together, you tell them, give them psychoeducation, tell them about what are the typical responses, what are a lot of the symptoms to watch out for, and then you very carefully talk through the event. You have people recall it, talk to each other about it, talk about how they responded, what their emotions were, what their thoughts were, how they felt about it. So you can see it's a very well-intended idea for prevention. One of the most common models of it, one of the most systematic models of it, was called critical incident stress debriefing. It was actually developed for first responders, for people who would go help the victims of a disaster, but it was then used with survivors of trauma. Over the years, they studied this, and in the early 2000s, there was a Cochrane report. This is sort of where they get a bunch of experts together to read through all of the literature in an area and try to come up with a review of what we know. And what we found was, it doesn't work. It either has no real effect, or people who received some form of debriefing were worse down the road. They were more likely to have PTSD than people who got nothing. So that was a key lesson, because here was a really well-intentioned idea that was not only failing, it was doing harm in some cases. And this has been taken into several guidelines. I just put this as an example. The European Network of Traumatic Stress Studies has some guidelines. They comment on these. Any guidelines you see now that are evidence-based, data-driven, are going to tell you this is not something you want to do after a trauma. So then, what do we do? How do we take what we know and actually make something that works? Well, when you think about it, first of all, most people end up not developing PTSD. So trying to do something with everyone who goes through a trauma has risk, because most people are going to come out okay anyway. So you have to be very careful with that. What you may want to be doing is thinking about selective prevention, thinking about finding people who are showing some risk factors and doing interventions with them. That may be indicated, that may be sort of where to focus. So what are some appropriate approaches? Well, first of all, I think we learned from this that forcing people to sit down and talk through it and process their emotions in the aftermath of it is not necessarily appropriate. If people select to do that, if people choose to do that, that's fine. We want to be there for those people. But if individuals don't want to do that, sitting them down and making them is not exactly a good idea. So then, what can we do? Well, let's turn to some basic research on mechanisms. What I want to talk to you about is sort of what are some mechanisms of how negative responses develop, and what does that tell us about how we can prevent trauma? And seeing my minute warnings, I'll go through some of it more quickly than others. Trauma typically involves heightened reactivity. When you go through a trauma, your whole body you're having a sympathetic nervous response. You're activated. But what we know is that elevated, even above the norm, reactivity is associated with later PTSD risk. So the people who are unusually elevated in how reactive they are after a trauma are more likely to have PTSD down the road. We also know that trauma survivors with PTSD have greater activation in the amygdala, the part of the brain that really processes emotions, than most people do, than people without PTSD do. Most people are having much more activity in their hippocampus come up when they're having memories. But people with PTSD tend to have that emotion center, the amygdala, lighting up a little more. Memories also tend to be more visual rather than verbal. They tend to be more imagery rather than words and meaning. So people have used that to think about maybe what we need to do is avoid having people focus on the emotional part, because that might actually enhance the chance of PTSD. And maybe what we need to do is think about how to either reduce reactivity after trauma or disrupt the emotional and visual memory processes after a trauma, so that people don't end up having these visually, emotionally coded memories. So let me go through, this part I'm going to go through sort of quickly and not spend as much time on. There are medications, so psychopharmacology medications, that are known to reduce reactivity. There have been a number of studies of people trying out giving people medication very shortly after a trauma to see if that reduces PTSD in the long term. Benzodiazepines and propranolol are things that sort of dampen reactivity. That should work, but it doesn't. So I'll just speed through it that way. There's no evidence that these actually reduce the likelihood of developing PTSD. Interestingly, hydrocortisone has been shown to actually reduce the chances of long-term PTSD with a response that seems to be associated with having enough stress hormones after a trauma to sort of deal with it properly. So that's one avenue that people are sort of exploring, is giving people hydrocortisone shortly after a trauma. Oxytocin is another drug that's been used. That should work. The effects there are mixed, and I'll leave it at that rather than belabor that point. There are other drugs as well that are even more sort of serious, from morphine to ketamine to MDMA, which is the street drug ecstasy. These are all actually being explored, right? People are really putting a lot of effort and time and money into thinking about how do we prevent PTSD with drugs. The results are mixed so far, and when you start thinking about the idea of giving an entire population of people who underwent a trauma drugs after the trauma to try to prevent that tiny sliver of people who are going to develop PTSD from developing it, you have to wonder if that's worth it, right, from a prevention standpoint. What are some other things we can do from a prevention standpoint? What if we could disrupt the visual memory processing that happens right after a trauma? Well, how might you do that? This is going to sound weird. Has anybody, people familiar with the game Tetris? So this is, video game, right, where it just comes down and you just have to rotate shapes and make them fit. So there was a series of studies done to look at whether or not, when people sit down and watch a really awful film clip, this is how people come up with analogies for trauma, is you make them watch something really awful on screen. And then afterwards, they had some people play Tetris and some people do something else. The people who played Tetris had fewer intrusive memories of the film clip over the next week, and they were less distressed by it. They actually rolled this out and studied this in a set of people who came into emergency departments after a trauma. They literally gave people little sort of tablets and had them play Tetris or do something else. And what they found was that actually in the first week after that, the people who played Tetris had fewer intrusive memories. But what they also found was a month later, those differences went away, and there were no differences on any other symptoms. So it's an intriguing idea, and you hear a lot about it, and there was a lot of press, and Tetris can stop PTSD, but we still have a long way to go before we figure that out. It has some interesting promise there. It would be easy, it would be cheap, you could just give people this as they sit in the emergency room, but we need a lot more research to know if that's going to work. Well, avoidance is another key predictor of problems after trauma. In naturalistic studies, it's one of the most common predictor of problems down the road. Recently, a group at Emory University in the US has tried out preventive exposure. So they have given people who have gone through trauma 3 prolonged exposure sessions, 1 in the emergency department and then 2 once per week, in the 2 weeks following. And they found that this actually does reduce the incidence of PTSD at 4 weeks and at 3 months. So not only is that true, the results are actually most obvious in people who experience some of the most severe trauma, like rape, or people who showed a genetic abnormality that was related to the development of PTSD. So it seems to actually be most applicable for people who have some predisposition already to developing post-traumatic stress disorder. So that holds some interesting promise. One thing to note is that they approached about 1,000 people and had about 100 say that they would even participate in the study. So as a wide-scale intervention, this is questionable. Also, if you think about a disaster, trying to find enough people to sit down and do 3 weekly sessions of prolonged exposure with everyone who went through a disaster is mind-boggling and near impossible. So it's got interesting promise again, but is it a true preventive strategy that's scalable? One of the things we know that's most predictive of PTSD is social support. People who have high social support are much less likely to develop post-traumatic stress disorder. This has led to the development of something called psychological first aid. Those of you who were here and were able to attend one of the workshops yesterday had an introduction to this. I'm not an expert in it, but what I know is it's described as an evidence-informed treatment. It hasn't been tested yet empirically, but it's based on everything that I've just covered. It's based on all the actual evidence out there. So what does it do? First of all, one of the key rules is to observe, don't intrude. Don't force yourself on people. Wait and see if they seem open to it. Right? Be ready for either somebody who wants to completely avoid you and talking about it, or to be flooded with discussion, thought, talk about what's happened. The goal is to reduce distress, assist with needs, promote adaptive functioning, but not to elicit details of the trauma. That's not one of the goals here. Again, learning from what has happened before. And to not assume pathology. Right? You're not doing debriefing because you assume everyone is going to have a pathological reaction to this. So these resources are available through the National Center for Traumatic Stress Network. That's a US-based network. They're freely accessible on the internet. They haven't been empirically tested yet, so that's important to know, but they are there. Cultures and thinking about norms of trauma also is important. Dr. Sadi and I are talking about trying to start up a study where we look at how people view similar events from different cultures and different backgrounds, and are some of them viewed differently? Do some people even think about those as traumatic, or no, that's just life, you know, those are things that just happen? And if they have differing views, what does that then do? Is that a beneficial thing? Is that protective? Or might that actually be risk? If people assume I should be fine because that's everyday life, but I'm not. So we need to understand these things and be able to try to employ and use that information to help populations who are experiencing this type of thing all over the world. I want to thank you very much for your time.